Hello, I'd like to introduce Dr. Farah Fourcand. She is a neurologist at the National Institutes of Neurological Disorders and Stroke, or NINDS, within the National Institutes of Health, or NIH. She's also a neurology resident at Georgetown University Hospital. Dr. Fourcand's resume is packed with research and awards and publications, as you can imagine, but the most important thing to stroke survivors is that she is bringing her knowledge into our world, speaking with us about new therapies and exercises and treatments that may improve our lives. She's coming to us today from the American Academy of Neurology Conference in Philadelphia. Please join me in welcoming Dr. Fourcand, speaking today on improving mobility and spasticity after stroke.
Hello, and thank you very much, Susan. So today we are going to be talking about improving mobility and spasticity after stroke. First, a disclaimer. So this information is for educational purposes only and doesn't replace the recommendations of your healthcare provider or is intended to diagnose or treat any health condition. There's no conflict of interest to report, and this is being recorded by Susan to distribute to the stroke survivor community. This is just a list of topics that we are going to discuss throughout the year. We've discussed different stroke subtypes, communication after stroke, common medications. We discussed Stroke Awareness Month as well. Today we'll be talking about mobility and spasticity. And later on, over the next coming months, we'll talk about mood and personality changes after stroke, some newer discoveries in acute stroke research, discoveries in stroke recovery and rehab, and then we'll talk about World Stroke Day, another talk about breaking down medical jargon so it's better to understand, and a Q&A session based on the previous talks, and then discussing setting goals for the next year. So first and foremost is what to do before a stroke happens, or in preventing a recurrent stroke after your initial stroke. So making sure that the risk factors for stroke are modified, meaning diabetes, high cholesterol, hypertension, and other sort of smoking and other risk factors for stroke. That not only decreases your risk for having a stroke, but it also helps the physicians in a different way. So when a patient comes to the hospital with a concern for stroke, we often, have different interventions that we can do, like TPA, that blood thinner medication, thrombectomy, which is the removing of the clot that may be blocking the part of the brain that needs oxygen and blood. And we often use this scale that we call a modified Rankin scale. And it's pretty much a scale from 0 to 5, 0 meaning no disability, and then 5 is death. So when a patient comes in, we assess them for something called their pre-morbid, meaning pre-stroke, or MRS, which is the acronym for that. And a person who comes in with a low MRS, meaning they were very high functioning before the stroke, we're more likely to do these acute interventions in them. So in the end, that makes the likelihood that your outcome will be better if you have a better outcome, or if you have a better sort of ability and functional independence prior to the stroke. So right after a stroke, whether it was a stroke in which you were treated sort of with supportive care, meaning no acute interventions like TPA or thrombectomy, or whether or not those interventions were performed, and in that case, the patient or the stroke survivor would be in the ICU and maybe be a little bit more limited. And maybe the person with the milder stroke would be in an intermediate care unit and just have their heart rate being monitored and different things like that as other testing is being done. But the most important thing after the initial phase where usually patients are lying flat to help blood get to the brain is early mobilization. So in the sort of acute or right after a stroke time, there's some experimental things that are in the works for sort of neuroprotection, which is meaning protecting the brain after a stroke or traumatic brain injury and different things like that. But that isn't necessarily the standard of care in the hospital. In the hospital, we primarily do the acute interventions, and then we, get people up and moving, start them on an aspirin, and is very important. It helps with what we call having adaptive neuroplasticity, meaning there's a good way and a bad way that your brain sort of reacts to the stroke. And when you get moving very early on, which in every hospital varies, it's better for your overall recovery. In the beginning, the brain is very plastic and can very malleable, and sort of utilizing using the strong side and trying to use the weak side can help to the body to adapt better, the brain to adapt better and have a better outcome. So advocating for yourself, and if you can't speak for yourself, whomever is with you, your family, friends and family, advocating for as much activity and early mobilization as possible can improve your overall outcome. So getting up and out of a chair, working with physical therapy daily, and in the end, if they're not able to come daily, asking the nurse to help you get out of to do as much activity as possible, and just not laying there. So in the early stages after a stroke, we usually, a patient or a stroke survivor will go to some sort of rehab facility. Sometimes it's a subacute, with less activity. Sometimes it's an acute rehab where there's more activity, and sometimes it may be home with physical therapy and occupational therapy at home or at a local center. So with the upper extremities, with the arms, typically, the sort of regular way things are done is the goal is to just to help you adapt to your new functional status. So let's say there was a stroke on your right side, and then your left arm is weak. Trying to strengthen the weak arm, but use more so the right arm to help you do things that the left arm couldn't do before. To sort of help you do the everyday activities of living, basic things for yourself, like brushing your teeth, combing your hair, drinking your coffee, and whatnot. But there's actually evidence that something called constraint-induced movement therapy may be a bit more beneficial. And what that means is using the weak arm, forcing the weak arm to do as much work as you can. In this therapy, the strong arm is actually constrained to an extent. And in this picture here, the gentleman actually has like a glove or a mitt on his strong hand to force him to use his weaker hand. So it may be very, very difficult to do, and maybe it would only be practical doing it, an hour out of the day if the arm is truly very, very weak. So in rehab, if you are aware of this, in the physical therapy and rehab people are usually very, they're very, very knowledgeable on these sort of things. But sometimes, just because things are sometimes done just kind of like going with the motions of things, or going with it, encouraging, say, hey, I want to use my weak arm more so than my strong arm. Instead of learning to compensate, I want to force myself to use the weak arm. Because compensation makes life easier and everyday things easier, but in the end, the weaker arm will make much less of a recovery, and likely to develop spasticity and other issues. So encouraging that after rehab as well, at home with family, with friends, getting yourself a mitt or something and like restraining your strong arm and forcing you to use the weak arm, even if it's just a flicker, even if it's just able to grab something. I mean, any sort of effort is great, because the longer you wait, even a few months, 6 months out, that function may not be able to return, and then people are often left with very, very little dexterity in their hand and just some strength maybe in the shoulder and up here, and they can sort of compensate, but not in the hand itself. So forcing yourself to do that is very important in the beginning, instead of learning to compensate to make just things easier. In the lower body, there's also a similar approach. This is called body weight support treadmill training. It looks pretty intricate, and it doesn't seem too practical to be done at home, but there are ways to sort of modify home environment to allow this to happen. So there was a trial, or there's been a couple, but a pretty recent trial called LEAPS trial, and they compared sort of standard physical therapy, walking exercises, and then this. So this sort of like almost lifts, takes some weight off of your body and some pressure, and then tries to allow you to have equal weight on both legs, the weak and the strong one. This allows your muscles to gain sort of a pattern of muscle activity and repetition that helps sort of your brain and your spinal cord to reorganize. And it's shown to improve walking and help with sort of the biomechanics that can be off after a stroke. And then medications for spasticity. So spasticity happens often on the weak side in the arm or the leg or both. There's many medications available, and this picture here is concerning. There's a ton of medications there, and it's, there's by no means should she be smiling about that. But our goal is to minimize these kind of medications, because after a stroke, there's medications that you need to be on to prevent a recurrent stroke. It may be aspirin, it may be a statin, like a cholesterol medication, maybe your blood pressure medication, your diabetes meds, or a blood thinner, whatever it is, based on what kind of stroke you had and why you had your stroke. So those medications you need. So we want to minimize the polypharmacy or too many medications. There's several. There's baclofen, which can, help with spasticity, but can cause some side effects, like fatigue and some confusion, which after a stroke, we want to be very weary of. There's other ones. Some of them are like the benzodiazepines. They are the kind of medications like Valium and different things that can also help with spasticity, but they can also cause those kind of cognitive sort of changes and confusion too. There's others as well, and then there's Botox. So we'll talk about Botox. So I say not all Botox is created equal, because there's many patients have tried Botox for spasticity, and it's very operator dependent. Now the physician administering the Botox may not be, maybe they do it for migraine, or maybe they do it for another indication, but for spasticity, it's a bit different. It's a sort of an art. The Botox needs to be injected like at the sort of end plate of the muscle, and there's sort of a whole sort of details to it that not everybody follows. So sometimes if a person has tried Botox and then they come several months, maybe a year later, to another neurologist and say, well, I tried it, it didn't work for me, it doesn't mean that it won't work. It means that, at least try again with your new neurologist and see if, the way they administer it or the muscles that they focus on might be different, and it might be beneficial for you. So it's important to keep in mind that it's trying it once or trying it, here and there, and not over the long term, and not really, having sort of a rapport with the physician and kind of knowing like exactly like how much experience they have doing Botox for spasticity, how comfortable they are doing it. It may, confound the future. And so now we're going to talk a little bit about some other treatments, therapies for motor recovery or strength, recovery of strength after a stroke that are not really standard of care and not widely used, but are available with sort of limited evidence for them. One of them is the sort of field of neuromodulation, which is trying to change or modify sort of how the brain connections are made. So a good example of that is TMS. So TMS stands for transcranial magnetic stimulation. We can just call it TMS. Pretty much, it is a magnet that is placed on the scalp. And in the case of a person with a stroke and the goal is for motor recovery, we would put it over the part of the brain that is in control of movement on the side where the stroke was. Now, TMS has evidence for different neuro and psychiatric conditions like depression and different sorts of things. But the evidence for motor recovery and for some other neurological diseases is not consistent. And there's research now into more why that is. Why is there so much variability and differences in how effective it is in one person and not in the other, which is probably what has precluded it from being, used more widely. One approach that I personally am involved in is trying to see if when TMS is given, if there's any association between how effective it would be and how much it, what effect it has, and how that relates to brain waves or to what we call brain oscillations, but it's just pretty much brain waves. So what we do in my lab is we put an EEG cap, and for anybody who's had a stroke, I think at least a few of you are familiar with EEGs, and we measure brain waves, kind of just like a wave like this, and then we put the TMS on, and then we assess, we have a certain marker that we use to assess how strong the impulse is, and we see if it changes from the bottom of the waves or the top of the wave, and then we do it also uncoupled, which is meaning just randomly, and we try to see if there's an association between that. In healthy people who have not had a stroke, we have found that on certain brain waves, actually, what we call alpha troughs, but it doesn't matter the detailed name, but at certain times in the brain waves, that the magnetic impulse is stronger and more consistent. So in the future, a therapeutic protocol or study design may be able to be made that delivers TMS correlated with brainwaves to make it more efficacious, more effective. So that's a promising area of research for the future. But presently, the data is limited, which is why we do research. There's other forms of neuromodulation as well that we can talk about at another time. So another therapy that's newer but not too new is the robotics, exoskeletons, and different sort of devices. So there's exoskeletons for people who have spinal cord injury and are paralyzed from the waist down, and then there's also these kind of devices for people after a stroke. So they kind of work in synergy with, or in conjunction with, how much strength you have and how much they can provide for you. So it's sort of like a complementary relationship. One device that a lot of stroke survivors I know have is a Bioness, which has been very helpful and much more streamlined than something like an AFO, but it's not that accessible. It's expensive, and a lot of people have trouble attaining it. So the ultimate goal with all of these therapies is that some of them are practical to do at home, Some of them are not that practical to do in a home environment. And even the ones that show benefit for recovery after stroke, there needs to be a way to make it more mainstream or more accessible to others. And that's where the whole advocacy thing comes in, not just for acute stroke research, which is really, and I'm personally going into an acute stroke field, so I appreciate the efforts on that front. But on the rehab side and all of these sort of elements, advocacy for this, and not just for research, because the evidence is there. It's the accessibility and making it practical for stroke survivors. That's really important. And here we have something called action observation. So it's like see one, do one, teach one. So in this sort of therapy are something called mirror neurons, which is like a sort of concept that that neurologists, our neuroscientists speak about. But in a way, what it really is that you observe an action. Like in this picture, the patient is observing somebody picking up an apple, and then there's this whole complicated process that goes on, and then it facilitates you to do the same action, more so than if you were just to try to do it without observing that action. Here we have virtual reality. So in this picture here, the gentleman is looking at I think it's a soccer game. And it also, in a way, is similar to the action observation. Observing this is much more, like observing the action happen of the ball being kicked is more effective than just having the patient stand there and trying to kick the ball. Again, through that whole mirror neuron process that we talked about briefly. This is also, a similar, so there's brain-computer interface, which sounds very, futuristic, matrix kind of thing. But in a way, it's also your brain and the computer sort of working in synergy together. So there's the computer interface is able to sort of interpret how much connectivity your brain has to that weak side of your body, and is able to allow you to make the effort you can and then push you to make that extra effort. So, it works also sort of in a synergistic way and can help with the reorganization of the brain and the brain adapting in a positive way and not adapting in a negative way. Meaning that, like we had talked about before with the constraint-induced movement therapy and forcing your weak side to work instead of compensating with your stronger side. Like I mentioned, advocacy is really what is needed to make these mainstream, because the evidence there is like evidence for many of these therapies, especially the ones that are more established. It's just the accessibility, making it practical for stroke survivors, and that's where organizations like Circle of Rights and different organizations come in, and hopefully in the next few years that there will be more availability and accessibility to these therapies, because they definitely hold promise. And on the back end with the research that's going on with neuromodulation, like with TMS, there still needs to be more research on that end before it can really be something that's generalizable to people, to stroke survivors. But once that's in place, also that will need, advocacy and sort of push and championing for that. So thank you so much for listening.